If you trace the trajectory of global health since the year 2000, you see what looks like a golden era of medicine. Child mortality plummeted, dangerous infections receded, and human beings, on average, started living significantly longer. This chart tracks global life expectancy. Look at the Southeast Asia panel's steep, undeniable upward climb. Between 2000 and 2019, people gained 8 additional years of life. Then, the line breaks at 2020, as the COVID-19 pandemic erased nearly a decade of hard-won gains. As the acute phase of the pandemic has ended, populations are slowly recovering. Life expectancy is creeping back up. But our confidence in that recovery relies on a massive assumption that we are actually measuring global health accurately. We base our international policies, our funding, and our future planning on these baseline health statistics. Trusting these top-line numbers without looking at how the raw data is actually collected on the ground leaves us vulnerable to the next global crisis. To understand the scale of the problem, look at the total human toll. In 2023, an estimated 61 million people died worldwide. Out of 61 million estimated deaths, only 12 million were reported to the World Health Organization with an accurately coded cause. That leaves 49 million ghost deaths, individuals who passed away without their specific cause of death being tracked by the global medical community. The United Nations maintains a set of Sustainable Development Goals, clear targets designed to eradicate disease, improve sanitation, and extend human life by 2030. We are currently failing to meet several of these targets, largely because of this missing data. You cannot cure a disease you cannot track. Reaching those 2030 international health goals is a mathematical impossibility when we are forced to fight our biggest public health enemies blindfolded. When we know exactly what we are fighting, we win. Take infectious diseases. Thanks to rigorous tracking and targeted interventions, global HIV infections have dropped 40% since 2010. In that same window, the Southeast Asia region aggressively monitored malaria outbreaks, allowing them to stay entirely on track for a massive 75% reduction in malaria incidence by 2025. But our progress stalls when we look at chronic conditions. Premature mortality from non-communicable diseases, things like heart disease, cancer, chronic respiratory issues, and diabetes, is stagnating. We are off track to meet the targets for reducing these deaths. These diseases are heavily exacerbated by silent environmental risk factors. In 2021 alone, exposure to household and ambient air pollution caused an estimated 6.6 million preventable deaths. We have successful track records against targeted infectious viruses, yet we are struggling against chronic diseases. The contrast highlights a stark reality. Our medical systems can only cure the conditions they can actually see. The mechanism that lets governments see a disease is called a Civil Registration and Vital Statistics System, or CRVS. This is the national backbone required for calculating excess mortality and tracking which diseases are killing people. This table breaks down the quality of cause of death data reported to the WHO. It reveals a severe geographic inequality. Routine mortality systems in many low and lower middle-income countries are incomplete, with dozens of nations falling into the very low quality or no data category. This graph illustrates the real-world consequence. Notice the high percentage of deaths assigned to ill-defined or unspecified medical codes. When a patient dies from a specific non-communicable disease, but a doctor checks a box for a vague symptom instead of the exact illness, the true cause of death becomes invisible. Without that specific code, the disease does not appear in national health statistics. Consequently, health ministries cannot secure or allocate the funding required to stop that exact disease from spreading further in the community. A broken registration system fails to accurately document those who have passed away, but it also misdirects billions of dollars in future healthcare funding away from the living patients who need it. Closing these global data gaps requires a move towards modernization. The WHO is pushing a transition to ICD-11, a fully digital, multilingual coding system. It standardizes how doctors record the exact cause of death, feeding precise data directly into national electronic registries. Right now, because their own routine systems are incomplete, many developing nations are forced to rely on periodic household surveys, funded by external international organizations. Building independent, interoperable digital health infrastructure changes that dynamic. It establishes data sovereignty, allowing regions to own their epidemiological outcomes and generate continuous, reliable data without waiting for outside help. Rebounding from the pandemic to reach the 2030 Sustainable Development Goals depends on this transition to local data ownership. It ensures the health improvements we observe are verifiable and supported by evidence. To protect the living, we have to accurately count the dead.